Hang on 1 second. Susan, I'm turning on the small recorder so I can have audio recording. This is Health, April 6th, 2020. And Susan, I took on the roll sheet. Sorry, I need to be standing here. You can actually see me now. Health committee attendance, and it looks like you have everyone present.
Thank you, Julie.
Thanks.
I'd like to call the April 6, 2020 Health Committee meeting to order. As Ms. Morlock had mentioned, we have all of our members present, so we have a quorum. We have minutes from the March 2nd meeting to approve. Do I have a motion to approve? Motion by Chung, second by Metzger. Are there any additions or corrections? If there aren't any, all in favor? Raise your hand.
Aye.
All right, any opposed? Okay, motion passes. Do we have any members of the public?
Chairperson, no, we do not.
Thank you.
You're welcome.
Next up is departmental matters is Ms. McKnight from the nursing home administrator. If she would, I think she's going to go to the podium.
Yeah, Jessica from the health department is here in 404, so she's going to join us at the podium.
Thank you.
Yes.
Hi, everybody. So I think you got my report. Did you have any questions or concerns or things you want me to specifically touch on?
Any questions? Member Metzger?
I don't have any specific questions that I'm going to address at this meeting, but I have a couple of questions and clarifications that I need from pages 7 and 9 in particular. So I will send an email to you and maybe CC Chairman Schaefer. Just a couple of clarifications that I wanted to have addressed, and I'm not sure today we don't have, I wasn't able to contact you in advance, and I'm sure you don't have your environmental health specialist with you today, so we'll get those addressed at a later time.
Okay.
Anyone else? Because I have several questions. Okay, Member Chung?
Yes, thank you, Madam Chair. I was just wondering if Ms. McKnight could give a sort of, I guess, a status update on the testing facility, how everything is going, and the numbers. I know that there was a sort of concern about the testing numbers not being as high as they anticipated, and I know that they've kind of relaxed the sort of, what do you call them? I can't think of it right now. The sort of qualifications, I guess, to be able to get tested. So I was wondering if you can give a sort of update on that. Thank you very much.
Sure. I don't have numbers for today. Yesterday was 44 tested, and then I believe we had over 80 tested. So it seems like I think on Sunday and Saturday, we had some numbers that were a little bit lower. 250 is the maximum number that they're capable of testing each day. I don't know if it's regional, geographic, that population-wise, we're just not as big as, up in the Chicago area where they're setting those numbers. The criteria was laxed on Sunday officially at 0800. So there was a request from IDPH to HHS on either late Friday, early Saturday to relax the criteria. And so now it is in the third category. So that's first responders, healthcare personnel, that they don't have to be symptomatic. And then the general public that is symptomatic can also go. So that's where it was expanded.
Do you think that it is because people are just taking care of themselves if they feel that they have the symptoms and are just not even bothering to go get tested and just assuming that they have it? And is that why maybe there aren't a lot more people going?
I'm sure is a possibility. I mean, we have done a lot of promotions over the last couple weeks of encouraging people to stay home, even if, you know, they have symptoms, that there's no treatment, that if they test positive, the, you know, the symptoms and everything, the management will still be the same, whether they have a positive test or not. I also think that just, you know, there's been a lot of confusion about the testing site, the testing criteria. So I sure think that that may have been a factor. I mean, it is a regional testing site that we've been trying to promote that factor, but I don't know if that has really gotten out.
And Ms. McKnight, if I may add to, and Chair, Madam Chair, if I may, I like to reiterate to all that will listen that this is not solely the health department's responsibility. And in fact, this is coming from the federal government. It's a pilot program. And then the National Guard was detailed to administer the tests. But in all, we are serving in a capacity where we have actually had to make phone calls to request that we be in the loop regarding the decision making. And that's not a criticism, more than just letting you know as a health committee that anytime there were requests to loosen the requirements for testing, we were made aware, but we're not really the decision makers. And so we're doing our very best to share the quickly changing information with everyone that we can. And we just want to share that with you because we've been working hard to share that with others. It's been a monumental effort to get this testing site going. And we wouldn't want anyone to think that it's just as easy as, and I know you don't think that, but we certainly have had our challenges in getting the right information to everyone. And we're pleased every day when more and more individuals are qualified to show up. It's hard to say exactly why.
Depending on, you know, the situation. So for COVID, you know, we are notified either sometimes by the healthcare provider if they know it's a positive test. Sometimes they find it in the electronic system. Our nurses in communicable disease, they may pull that up and see a positive. So once that positive case is identified, then those communicable disease personnel, they're contacting that individual to find out, you know, now the criteria is 2 to 3 days prior to when they develop symptoms. Where have they been? You know, who have they been around in close contact? So that then, yes, we can then work out. So starting in and then working out and identifying those close contacts, reaching out to them to let them know, you know, not by name who they've been in contact with, but they are a close contact. And so for them to be, you know, here's the symptoms for the next 14 days, you should be quarantining yourself and on the lookout for those symptoms. If you develop those symptoms, what you should do. And so it's really just educating people on, you know, what they should be looking for. And then again, also close contact. So that is difficult sometimes to identify, you know, who is a close contact, thinking, you know, of myself, where have I been the last 14 days? Luckily, it's been, you know, home and work. But the stay-at-home order has definitely made their process much easier in that investigation because for most people it is. I've been home, I've been at work if I'm an essential employee, or maybe I was at the grocery store. And in those cases, then we likely wouldn't have to contact anyone because they're not a close contact. So again, 30,000-foot view, I hope that answered your question.
Mr. Robustelli.
Yeah, that's very helpful. I actually appreciate you asking that, Chair Schaefer. One question I had was, what about those that are presumed positive? So maybe as we've gone through these iterations of not having the testing and as available as it is now over the last few weeks, a doctor who somebody calls, they have all the symptoms, they have eliminated the flu and other things. Do those get reported to you, and do you do the same contact tracing for that group, or is it only when they are identified as positive through one of the tests and it's reported to you that you do that?
Yes, we're only notified of laboratory confirmed positives. So those presumptive, then hopefully their medical provider is educating them on the quarantining process for 14 days. And we've done a lot of communication leading up to this and through this with those healthcare providers on information that they should be providing to those individuals. But presumptive positive, we don't get any notification of that.
Could you define what close contact means?
Mm-hmm. So close contacts in this would be 6 feet for between 6 and 10 minutes. So over that time period. So anyone that you've been in that close contact. So an elevator ride, unless the person sneezed on you or it was a long elevator ride where you were on there for 10, 15 minutes, that wouldn't necessarily be a close contact. Same thing in the grocery store, unless again, that person has sneezed or coughed on you, then wouldn't necessarily be of concern. Again, why we're encouraging everyone to wash their hands, because more than likely it's the droplets that fall on a surface, you touch the surface, touch your face.
Okay, and my other question is, okay, Member Gordon?
Thank you, Madam Chairman. You go ahead and then I'll follow up. I'll follow you. Thank you.
Okay. When it comes to food safety, when people are ordering out and getting their takeout or getting it delivered, how much concern is there on any kind of transmission in that respect? I know that they've said throw away your food containers and whatnot, but has there been anything that we should be concerned about with that process? And what is the health department doing on their normal inspections then as to how to inspect that kind of activity versus being in a dining room with a bunch of people and looking at that part of the operation?
So I guess I'll start with that first. We're doing minimal inspections, but still doing those inspections of those facilities that are open. And it's similar to norovirus or any of those other viruses like that, where if there is a case in a food facility, then they're given guidance on cleaning. But in terms of food preparation, not as much concern, because those foods that are getting cooked. But your food packaging, again, shouldn't be a concern as long as you are washing your hands. So even if that had been touched by somebody, if you're washing your hands, that's doing that mitigation.
Member Gordon?
Thank you, Madam Chairman. We have heard, of course, the phrase presumed or presumptive positive. And I don't know if you could give me a clinical distinction between positive and presumptive positive, but I'm curious about it because it does influence how a patient, and I believe it might influence at least how a patient is treated.
So I'm not a nurse, but as far as I know, I'm not sure if presumptive positive is a clinical diagnosis. So as far as I can tell, it's something that is being just assumed positive. And so because testing is not available, then to treat it as if it is. So not necessarily a diagnosis per se, as more of an instruction on how to then go about your life.
Thank you.
Member Metzger?
You're still muted, Member Metzger.
I'm sorry. I guess
Okay.
it's better I'm muted and talking than not muted and talking, right? So I have a similar question, and it comes with what I see as criticism from media that the numbers that are being provided as to positives in each county are really inaccurate, and it's because of this presumed positive that isn't being tracked and all that criticism. But that's, I'm assuming, because it's not a requirement by the state for you to follow up and track those, or help me understand why that you don't keep track of those, because the criticism is pretty heavy.
So there's a list of reportable diseases and conditions through Illinois Department of Public Health. And so COVID is one of those reportable conditions, meaning that when there is a laboratory positive confirmed case, then it is reported to us through an electronic tracking system. Those presumptive positives where there's no laboratory confirmed case testing, we never even receive notification of that. So that would only be then maybe, you know, in a patient's medical records at their physician's office, that, you know, in their notes that was what they were told. So there's no, again, diagnosis of that, and therefore no laboratory confirmation, and it's never given to us at the health department. It's never reported. So yeah, lack of data is something that, you know, for people like I like epidemiology, and so it's going to be something that when we go back and look at this pandemic, it's something that we're going to have to address, is that we didn't have all of the confirmed cases.
But it's not by lack of wanting the information, it's the lack of not having the information, correct?
Correct. Yes, it's not a requirement that is reported, so therefore it's not reported.
And that's true of many other diseases, correct?
Correct. Yes, there's a list.
So you're not treating this any differently than you have any other required reporting.
Yeah, so one good case, I guess, would be flu, influenza. So there is data tracked influenza-like illness. So ERs, hospitals, we do have those reports now where they show us where they may not have a confirmed influenza case, but they have reports from hospitals. So going forward, that may be something we have from COVID, where we have reporting from hospitals or you know, those ERs where they have seen COVID-like illness. But at this moment, we don't. So I know that CDC, IDPH, they're working on getting a similar report that we get. We get a weekly influenza report.
Member Robustelli.
I appreciate that that last bit there, because I was wondering if there was any other examples where the hospitals or doctors may not be required, because like you said, there hasn't been the supply of testing for them to say with a surety that those that they believe have been that are positive for COVID are, but they're acting as if they are. And it just seems like if they would report that to the health department, that would give people some assurance that at least that contact tracing is occurring. So I think if we're aggressively going out and educating our local the physicians and practices, perhaps we could make a request that they report those moving forward to the health department, just so we have a sense. I mean, it's not a number that is going to be scientific in any way, but it's a number that helps us move towards ensuring that the best practices in terms of social distancing are taking place. And I don't see any harm in that in terms of us establishing that. The question I wanted to ask was really more general, two parts. The first is just about the capacity at our local hospitals. I wonder if you could share a little bit about the number of ICU beds and kind of where we are in terms of the impact that this is having locally on our healthcare system.
That I couldn't expound on about the hospitals or their capacity, other than, you know, the EOC, Emergency Operations Center for the county, is in operations. And so they are part of that, and therefore the communication is ongoing to the EOC of needs. So there's communication, but I don't know off the top of my head, numbers and capacity at this moment.
Since Mr. Martin is probably working, I
Yeah.
think he can address some of that.
This is like a all-day thing for me. Right now, both hospitals are below capacity of what we would normally be at on a regular day basis. So we have a lot of, because people aren't coming to the hospital like they were. So both hospitals are not at the capacity they are at. We both are at a place where visitors are not allowed, or well, only one visitor per patient to be in the building. So we have more beds than we have patients now, quite a bit. There's, I won't get into numbers, but I can assure you that we have both Advocate and OSF have plans for surge capacity, and we're not anywhere close to a trigger at that point here in McLean County. I don't know if that answers your question or not.
Thank you. Did you have something else, Mr. Robustelli?
No, I was just going to say thank you. That does help, and it's a question I've gotten and I've seen some reporting on, and I just think figured I would take this opportunity to ask, just so people knew that is being tracked, and that we have plans for surging capacity if we need it.
Hey, I have one more question. And it's kind of like a hypothetical type question. And I know that we'll have JDC and adult detention, medical, and Ms. Wagner from the nursing home, because this kind of applies to them, but it also applies in general to the rest of the population too, is that when we've seen like assisted living locations, group homes, things like that become like a little cluster. And would that logically not occur eventually everywhere because of the nature of those kinds of operations, whether, like I said, whether it's, the county, the jail, or the nursing home, the jail, but even, the developmentally disabled group homes that they have, any assisted living facilities that are even private, not necessarily government owned, wouldn't logically eventually everybody become infected?
It's definitely possible. And so the flattening the curve that you've all heard about, that's what we're trying to do, is the assumption that we're still going to end up with the same number of people in the end that do become infected. It's just spreading that out long enough, over a long enough period of time, to give our healthcare the capacity to handle it. So, unless there's a vaccine, unless something, we're learning more about this virus every day, so that could change, but we're kind of operating under the assumption that a lot of people are going to get this virus. It's just over what period of time is it going to be? And again, let's hope for a vaccine. Let's hope for, something else that we learn about this virus. But yeah, to prevent the clusters also is what we're doing. So it may be that, everybody from a long-term care facility does end up with it at some period of time. We hope that's not true. But if they did, would we have the capacity then to help them?
Thank you. Member Metzger?
I just want to clarify one thing that Mr. Robustelli mentioned, and that was, he was asking questions about beds. That is not something that the county is responsible to keep track of. Is that what you said, Mrs. McKnight?
The county health department, it does not keep track of that, but in the county EOC, the Emergency Operations Center, that is something that we communicate about, because we look at alternative treatment sites. So if the surge from a hospital was so much that we were needing to look and find a facility to have that alternative treatment site, that's something that the EOC looks at possible.
Very good. Thank you.
Member Martin?
PH does require us to tell how many beds we have twice daily. There's like 4 or 5 different agencies that are requiring us to report 2 times a day how many patients we have, how many beds we have, what kind of our PPE. It's pretty much overwhelming us right now as far as how many state agencies are requiring all of that information. That is being kept track of, but it's through state agencies, not through the county.
Thank you. Member Gordon?
Thank you, Madam Chairman. Following up on what Member Martin just said, pardon me, I'll direct this to Ms. McKnight, or perhaps to Administrator Rodriguez. If the state is tracking that information and requesting twice a day that the hospitals report, is that information forwarded to the county level?
Not necessarily. So with Mr. Martin's participation in our EOC through a different hat that he wears, we are made aware of it in the Emergency Operations Center. But Ms. McKnight can correct me. I don't think that that is something that's trickling to the local health departments, mostly because it is not the actual role and responsibility of the health department to effectuate any alternate medical sites. The EOC is involved with situational knowledge and even any assistance that the hospitals might need that they can provide to create an alternate medical site. But at this point, Member Martin is likely inundated from several state agencies that do not then trickle that information to our local health departments. It's not part of our role and responsibility in that regard.
Member Robustelli?
I was also going to ask about, I know that the way information is trickling in, the best information that we have is sort of through our health departments at all the different levels. And I wonder how you are taking that information and sharing it with county departments that may have, that may need to be thinking about general populations. So I think Chair Schaefer brought up an example of the nursing home and the juvenile detention facility and also our county jail. I just wonder, are we making sure that those recommendations and the populations that are most vulnerable, that those that are charged with protecting those groups have the very best information about who those groups are and are doing the assessments of who has underlying conditions, all of the inventory it would take to just know that if somebody came down with COVID, their healthcare results could be more significant, more dramatic.
Yeah. So in addition to, we have quite a few internal calls. So, countywide calls where and so
internally in McLean County government, especially relative, Member Robustelli, to the nursing home and the adult and juvenile detention facilities. We probably almost 3 to 4 weeks ago, implemented twice a week, Monday, Thursday calls with those particular department heads, even before we had our first positive COVID case in the county. And we did that because we knew already that we needed to be formulating policies and procedures that adjusted to the changing landscape relative to what COVID was bringing us. I also know that perhaps each and every one of those department heads, but specifically Ms. Wagner, became involved in additional phone calls with IDPH relative to long-term care and COVID management, and also the Centers for Medicare and Medicaid Services were holding several calls, and they still might. She'll have to expound on that. There's no way that I could be involved in all of those calls because, as Ms. McKnight mentioned, there are calls with IDPH, calls with CDC, calls with CMS, and all of those are very facility specific or long-term care versus other specific, and that's been fantastic. And so the reason I convened those Monday and Thursday calls was so that these fine department heads that report to you and health committee could share information, talk about their each specific needs, and then as also a member of the Emergency Operations Center that I am, I can push information to those department heads. So when the Strategic National Stockpile sends a shipment to us of PPE and of hand sanitizer, and it's available to long-term care facilities, I can get on the phone with those folks right away and say, please email this individual if you need this supply. And so that's been some of the ways we've been trying to manage all of this very good regulatory information. I know that each and every department head can probably tell you a different avenue through which they are reached through their regulatory agencies, and they bring that to me or I bring it to them as fast as we can.
Thank you. If there's no other questions, Ms. McKnight, would you like to repeat when the health department has their Facebook stuff and that kind of thing?
So Facebook Live is every Tuesday and Thursday at 2:15. And then we also do participate in media calls on Monday, Wednesdays, and Fridays at 2:15. And so they're for the media, but we know we have other people that are on those, since we're not doing, press conferences like some of our other agencies are doing for, social distancing. Those media calls are there, they do exist, but we know that the media will take the information we give them and have stories, but also the public is not, they're not forbidden from being on those calls.
Thank you. Thank you very much for that information. I think it's been very helpful for all of us. And I think that the memo that you sent out with all of the structure and the responsibilities and things like that, I think that was very good also to let us know how you actually have a plan and how this works for the county.
Thank you.
Thank you.
Okay, next up is Michelle Welch and Jason Tabb from Adult and Juvenile Detention.
Just a second. I don't have them unmuted.
Craig is unmuting them right now. Actually, Chairman, we have Cindy Wagner next. Is that okay? I don't know if there's been perhaps you and I have a different.
Nope. I read it wrong. Sorry.
I was worried that maybe there was an amended agenda. So if I may, could we have Ms. Wagner go next?
Yes, we can. I misread my agenda. So Ms. Wagner.
No worries.
Hello.
Hi.
Hi. Sorry. You have my regular report in front of you. Are there any questions about the information presented there?
Anybody have any questions for Ms. Wagner on her general report? Because I had some questions on the narrative that you had. And I don't know if Ms. Rodriguez sent you those questions that I asked?
I did.
I did. Yes, I
Okay.
have those. Yeah.
Okay. The questions that I had were that, last month you said you're going to have this report for us about your plan was to increase the census and reducing costs and improving the quality measures, and that you would have some outcomes for us. And that was not in the packet. And I guess what has changed because of COVID and the way you have to do things, but what kind of quality measures or what kind of outcomes have we seen with that since there was no report?
Okay, well, and I do apologize for not submitting the report. We have been extremely busy out here at the facility, as I'm sure you can imagine, with the having to shut down to visitors and working with FaceTime and Skype to keep the families in touch with their loved ones. We've had a lot of illness amongst our staff, no COVID, fortunately, but for precautionary measures, people have been off. So we are all of the management team has stepped up out here at the nursing home, and we are all putting in extensive hours. We are helping on the floor to deliver meals, to help our residents stay entertained. The nurse managers are covering a significant amount of extra shifts out here as people are calling in. And so we've just, in between educating the employees and doing the employee screenings before people are coming into work, and all the way down to doing hair in the beauty shop because our beauty operator is not allowed to come in the facility. We have just been very, very busy keeping everyone safe, happy, and healthy out here.
Okay, thank you. And then the question on the revenue update that I had, to me, when we talked about it last month, we talked about an escrow account, but I don't, from what you wrote in the packet, I'm not sure that why we still aren't going to create an escrow account.
Because we can't. We had a discussion with Ms. McNeil, the county treasurer, as well as the outside auditor who does the auditing of the county operations, and we've gone through everything that occurred with the audit and everything that we currently have in place, and there is no other way that we can put money into an account or put money aside other than what we are already doing.
Ms. Metzger?
Then that brings me to my question. If we can't do anything more than what we've been doing, then how can we avoid the situation that we've had in the past? Because that's what we absolutely have to avoid. So we need some kind of internal, if we don't have a specific escrow account or whatever we want to call it, or a specific account to keep track of this, what can we expect at the nursing home or through the treasurer or auditor? I'm not sure who would be responsible, but we can't have the kind of situation that we've had occur in the past. So what are we going to do to prevent that?
We have spoken with OIG, who is the agency that oversaw the audit, and we have asked them. We have also reached out to other facilities, other county facilities in the state, and reached out to them to see if they are doing anything differently. And we are consistently told the same thing, that it is a systemic problem within the state of Illinois with the Medi system, and that the best that we can do, which we are doing, is Rhonda, our bookkeeper, and she is here in the room, is she's monitoring the accounts that we know are incorrect. And she's aware of those accounts. She knows which accounts those are. However, all we can do is continuously call Medicaid and ask them, are you going to update your system? Do you have this information? When is the system going to be updated? And we are continuously told the same thing over and over again, that they will get to it when they get to it, and we are one of many. So right now, what we are doing, as I said, Rhonda is monitoring that. She's watching as monthly statements are coming in to see if there has been any adjustments on those accounts. But in the meantime, there is nothing else we can do to offset that money.
When we spoke with the auditor, this is Rhonda, by the way, when we spoke to the auditor, she said the way we were reporting it on our accounts receivable was the only way you really could do it. We're not hiding any money. We're not banking any money anywhere else. It's very visible. So when we do get audited again, it will be easy to see, but we don't know what dates they're going to audit when they do audit. So there's going to be some accounts that we've been overpaid on that they probably will never take their money back on. There's going to be some that they will, but we don't know we don't know which accounts they're going to be and which time frame they're going to audit us when they do audit, because they typically do it about every 5 years, and the audit span is usually around 18 months. So when you do the math and you look at that time frame, there's going to be a big gap in there somewhere that never gets audited. So if somebody has a better way of doing it, we have tried, we have checked with everybody. Other than reporting it on your AR as an overpayment is the only way you can do it.
And if I may, Rhonda or Cindy, when you refer to the auditor, you are talking about our external auditor, or are you speaking of our county auditor? Because I've had
The external, yes, the external auditor.
I've had both work with you, and I'm sorry I interrupted you, but you're speaking of Clifton Larson Allen consulted with you in regards to this, correct?
That is correct.
Thank you.
Member Robustelli?
I wonder if you could talk a little bit about the employee screening process that you referenced, Cindy, just in terms of what goes into that, and what happens if somebody ends up sick, and what the process is for those employees.
Sure. We have a screening tool that was provided to us through the Illinois Department of Public Health. Our nurse liaison, since she is not out at the hospitals right now, she is assisting us with monitoring employees as they come into the building. And there's a checklist that they have to complete. They have to check off if they're having symptoms of anything. They have to have their temperature taken. And if they have a temperature of 100 or higher, or they are symptomatic of anything that's on the questionnaire, then they are in turn sent home until they are fever-free or no longer exhibiting those symptoms. Now, we've had 3 nurses that have been symptomatic, that had more than one symptom. They did go to the testing site, they were tested, and they all 3 have come back negative. Yeah, thank goodness.
So that's thank you for that. That's what I was going to ask, because I know that the thing about this that has been so difficult is the asymptomatic carriers. And so I wondered, now that testing has laxed and there's some capacity, whether it would make sense, given how vulnerable this population is, to have people more widely tested, even if they're not symptomatic, just out of an abundance of caution, and given that there is the capacity to do so.
I don't think that that's really what's recommended at this point. We are wearing, all employees now are wearing masks in the facility, not just the direct contact people, but also all employees, dietary, housekeeping activities, everybody, et cetera. So we are putting every preventative measure in place that we can. In addition, we did have one resident that we were questioning some symptoms. that resident was sent out, was tested, was not diagnosed with COVID, and is back in the facility. So we are just, you know, our antenna are up, and we have heightened awareness, and we are just trying to be as proactive as possible anytime we are seeing any indicators of any type of illness within the residents. In addition, the residents have their vitals taken every shift. Once every shift, we're taking their temperature, respirations, pulse, and during the period of time where we had a concern about the resident that was sent out to be tested, we actually increased that to twice a shift just to be extra cautious, just in case. And so we are, you know, as I said, we are just trying to be as proactive as we possibly can and staying on top of everything.
And then this last thing is just really just a question about ways that the community can help support some of those residents. I'm sure with the visitor restrictions and other restrictions, this is really hard on some of the residents. And I've seen in some places there have actually been opportunities for community members to volunteer to just, you know, have conversations with some residents in nursing homes and long-term care facilities, just to be basically like a person that's keeping them engaged and talking to them. I wonder if we're seeing any of that elsewhere, and if that's something that you guys are considering, as this seems to be something that will go on for a bit longer, particularly for the residents in a nursing home facility or a long-term care facility.
Sure. We've been very fortunate in that most of our families are very active with their residents here at the facility. And so because we do have access to FaceTime and Facebook Live, we have been having families call in, and we've made that available for the residents. We have had some people come out and put decorations, because we are a ground level facility, so they put decorations on their loved ones' windows, and they've come outside their windows and been talking to them and visiting with them. We've also been very fortunate that some local groups in town today, for example, Eastview Christian Church donated sandwiches and chips and cookies for all of the staff here to help boost morale. We have an agency that did supply cloth masks to us, in addition to a couple of our employees who are sewers and are taking care of that. So we have been very fortunate with the support that we have been receiving out here.
To follow up on what you just said, when you said the cloth masks and the sewers and things like that, are you having any problem keeping up with the PPEs that you need?
Not at this point. We have been in contact with the health department and with Dave Hopper, and we right now have everything that we need.
Anybody else have any questions? Member Metzger.
I'm sorry, but I have to go back to the revenue. So my question again is, I have two questions. Number one, we had an overpayment that we had to pay. Did we have fines associated with that also?
No.
No.
Okay, that's good, because that'd be even worse. I didn't think we did, but I wanted to make sure. And so my second question was the question I had initially: what are we planning to do to avoid this from happening, a significant overpayment situation like we had before? Did I hear nothing, or what are we, where are we at? I didn't feel like my question was answered.
Sure, go ahead.
Okay. I don't know, I really don't know what you can do, other than we stay in contact as much as we can, but within the last, I would say 2 to 3 weeks, getting a hold of a Medicaid caseworker is virtually impossible. I don't know if they're not working, we don't know what's going on, but we leave messages with our caseworkers and case managers for callbacks. It's an ongoing problem within the state of Illinois. It's not just us. and they pay incorrect because they don't update their system. I can't, all we can do is keep filtering the information to the case managers as far as what we know as being the correct liability for that resident. But if they don't input it in their system, there's nothing we can do about it. You know, like I said, after talking with the auditor, I felt better about how we've handled this because I don't know of any other way you can handle something like this. It's not because we're reporting information wrong, it's because we're getting paid wrong. And if we could control how we get paid, that would eliminate the problem, but we can't. The state of Illinois is in charge of that. So until they fix the system, this is going to continue to happen.
So is there something we can do to have a line item, you know, the average on a quarterly basis or average annual overpayment, so we can have a line item so we're not shocked and we don't have to do these emergency appropriations at the last minute to correct it? I mean, is there something that we can do? We know we're going to have these overpayments. So can we look at something maybe, you know, in the past year or 18 months, we have seen overpayments of $50,000. So we're just going to put $50,000 in a line item in the budget in the future. Is that, it's just those surprises, or 200,000. I mean, whatever we need to do, I just think we need to be proactive so we don't have these shocks. And so it doesn't look as, I mean, that really would, it looked really bad. And I realize now that it wasn't necessarily the fault of anyone. It's just the situation, but I think we need to financially be accountable to that somehow in our budget, I guess. Or maybe the auditor or whoever is working with our budget would say no to that. I don't know, but it just seems that we should be accountable to it somewhere in the budget.
This is Cindy, and we did discuss that. We talked about that as a possibility, and could we do something like that? But again, it goes back to, you don't know when you're going to be audited. You don't know what time frame you're going to be audited for. So there would then be money just sitting there on the books, and that money would then may never be recouped, because we did talk about that as an option, but that turns into just kind of a bookkeeping nightmare then.
I guess if you didn't spend it, it's not, I mean, it's just a line item. So it's not like you put it away. It's just what you would anticipate. So I guess I'm not an accountant, so I shouldn't even be questioning this, but it just seems that we need to be accountable to something so we don't end up with a $50,000, $75,000 hit and we have nothing in the line item to cover it.
Well, if we knew when they were going to audit, if we knew what time frame they were going to audit, it would be real easy to do that. But since we don't know, we may be pooling money and putting it aside for something that's never going to get paid. And then what are you going to do with that money? You got that money sitting there, and if you get audited, somebody could ask you, why do you have that money just sitting there? What is it attached to? And I don't know how I could even answer that question, because it almost turns into like a fund that nobody really knows who that money belongs to, if that makes sense. And I don't want to be attached to something like that. That would be scary to me. That would be very scary. So like when we were talking with the auditor, she said the only way you can do this, the only way you can actually do this, and you're being legit, you're upfront, you're not hiding any money, it's just sitting there on your accounts receivable. It's there for them to see. They can audit it, they can look at it. I just don't know how else you could handle this, because I don't know when they're going to audit, what time frame.
I think that the concern is to try to be proactive instead of, yes, nobody knows when we may be audited again and for what period of time we'd be audited for. But I think that nobody wants to have happen what happened before. And I think that that is what the goal was, is to try to avoid that and to figure out the best way. And it's not by hiding money or anything like that, but I think that this is a conversation that maybe we'll have to continue, and maybe also through finance committee may want to look at this kind of thing too and address it through finance. I'm not sure. On processes and procedures and auditing and whatnot. So I think that the concern is there, I think, by all the members of the committee, that we don't want to be in a situation where we were before, and what way we can then avoid it for the future. So that's, I think that's where we're at on that one. Is that correct, Catherine?
Yes, that's exactly my concern. So we probably have talked about this enough today, but I think that we probably have additional discussion on budget line items, those kinds of things, and maybe it's through finance. Speaking of finance, I guess we've got the other thing to talk about too, right?
Yes, but I want to ask one more question about, before we get into that one, because on your monthly report, one of my questions that I had, and I've kind of, now we have a whole like year's worth since we started adding those exception expenses in there. But I would think, this is just me as a person that's kind of logical, that expenses are going to be pretty consistent every month, not counting those exceptions, but they would be pretty consistent since our census is consistent. It's not like one day we have 100 people in there and the next day we have 120 and another week later we have back to 80 or anything like that. It's not real big fluctuations in our census. And so I guess there was in that questions that I had sent, there were like a couple of months that I looked at, like August and September of 19. If you look at those 2 months, there's a big disparity. And then like January and February of this year, where there's a big disparity in expenses. And so I guess, can you explain why there's such a big disparity in those expenses when we don't have any of those exceptions? And even when those exceptions do occur, sometimes there's still that big disparity there.
Yes, it all has to do with payroll and the way that the pay periods fall. So for example, in January, we only paid out $148,705 total for the month in payroll, just because of the way the pay periods fell. It was only one payout that month. So then in February, the way the payrolls fell, we paid out $532,810. So you're talking about almost a $400,000 difference in the way the pay periods are. And that's because the way our pay periods fall out here, we're actually 2 weeks behind before the pay date occurs, if that makes sense. So we actually got paid in the middle of January, but that was for December when we got paid. And so the same thing, you had asked about August and September, and I went back and pulled that. September, we only had $350,000 go out in payroll. In August, we had $530,000. So it all has to do with payroll and IMRF and Social Security and all those related expenses.
Member Metzger.
I guess I'm confused by that, because payroll is, most organizations, it's that way. It's always in arrears. So why is it any different for your organization as it is for a different organization within the county or within any? I mean, that's why my payroll is, when I get my paycheck, it's not for the work that I just finished, it's for 2 weeks prior. So I'm confused as to how that is impacting. I mean, net pay is net pay.
because the way ours falls out here is it's actually it's 2 weeks prior and then there's a week in between. So the pay periods just, the way that they fall, they just fall differently with the time buildup in the prior month.
Can we find out if that's unique to the nursing home, or are we seeing that in transportation, in our highway department? Are we seeing that everywhere else too? I mean, if we did an expense versus revenue, well, I guess we don't have the revenue. I don't know. I find that unusual that it's always about payroll. It just seems odd.
Mr. Opistelli.
I think centrally it's about revenue. It's not about payroll. It's not about expenditures. It's not about one time. I mean, we are not bringing in enough revenue. So I don't know I think that's the challenge we've faced. That's the challenge we continue to face. That is something we're trying to get ahead of. And so I think spending time on why it is that we have these peaks and valleys in expenses, when revenue centrally is the challenge that we have. Doesn't matter whether it comes more in one month and less in another. If there's not enough revenue over the course of the fiscal year, that's the problem. That's what we're trying to grapple with. That's the challenge we face. And so to me, I think that's where we should put our time and energy, is to try to figure out how we solve that problem, and then grapple with these other things. I mean, this issue of the reimbursement and the auditing, it's very difficult to be proactive about something unless we're missing something, which I don't have enough information to say one way or the other. When it happens sporadically, unannounced, and there's not a pattern of behavior. So how are you going to create a line item for something that you don't have a sense for what you want to budget? And you could do it. You could say, we're just going to pay $200,000 a year and put it in a line item. But unless there's something that we're not doing correctly, or something we should be doing correctly, which I just don't have enough information. It sounds like an auditor told us, no, there isn't anything that we could do about this. If that's being contested, that's a different issue. But if we agree with the auditor's opinion on this, or that has been given, or we want more information, it'd probably be better to spend time on that than it would trying to figure out how to build a budget line item to do something that right now I have no idea how you would build it. What would you build it based on? So I just it all comes back to the revenue side of this equation, and that's what's really challenging us. It's not the peaks or valleys of expenditures. It's how much we bring in versus how much we're spending net, and that's the problem we have. So hopefully we can figure it out. But I think spending too much time on these little things takes away from the bigger picture, which is we have to figure out how to increase census at the nursing home, and we're not going to be doing that over the next couple of months, given all the things that we're facing. So it's a big challenge, but I appreciate that there is some consultation with external auditors, and I would say maybe there needs to be continued work along that so that we get the best information we have available to figure out if there is anything that can be done to solve this budget influx issue. But if we don't solve the revenue issue, it won't make any difference.
Member Metzger.
The revenue swings are huge too, though, Member Robustelli. I mean, 300,000 between one month and another. And I don't disagree. It is the revenue that is where we need to concentrate. But we've got these revenue swings of 300,000, 200,000. It's difficult when you look at these numbers to really be able to disseminate or determine what we can do, other than, I mean, obviously the census, no question. And I totally agree with you on that. We're not going to be able to address those issues currently, But there are some other, I mean, the revenue is just swinging all over the place, and the expenses swing too. And that is hard to get my head around. So that's kind of where I'm at. So I apologize if you think I've been taking too much time, but I think we've got, I mean, when people look at this, you'd have to question it.
Ms. Rodriguez?
Yes, Chairman Schaefer, I will humbly suggest, and I'm not certain if she would agree, but our treasurer, Becky McNeil, makes a presentation to the Finance Committee each month and includes a very comprehensive nursing home report. And it's in that venue that I recall her explaining often and regularly the fluctuations relative to the payroll issue, obviously noting the revenue challenges that the nursing home has faced for an extensive period of time. And I wonder if occasionally, maybe even quarterly, she could provide that to the Health Committee. And that's something that perhaps Chairman Schaefer and I can talk about offline and consult with our treasurer about. But I find her report to be very helpful in understanding the overall picture of the nursing home. And perhaps it's regrettable that it isn't also shared in the same way with this committee based on this discussion. So I would never be so presumptuous to say that that's the right course of action, but it's something that I could explore to see if it could provide a deeper explanation into one of our financial officers' view of all of these particular issues that you're bringing up.
We have asked for the report that she gives to the Finance Committee to be sent every month to the Health Committee members, because it usually happens after Health Committee, and it's not the timing of the month, because we're usually the first committee to meet, that it's not ready because it's too early in the month for her to have that done. And I know that we haven't been receiving them on a very regular basis. So I think that maybe we just need to go there and look at, see, and work on that process too. And then have the treasurer come periodically, especially when we have questions, which then I think Member Metzger might start on the question of what finance was asking and the revenue question that she had at finance.
Well, thank you, Chairman Schaefer. When I go back and I compare what we get here and what we get in finance, I can't get the numbers to come out. I'm sorry. And I don't know why, but they don't come out. And when I look at this, and so I guess that's my frustration, is that we get something in finance and it says, here is our revenue, here is, and here's the bottom line. And the numbers aren't the same. And I don't understand why not. So that's, and this past month, and I do appreciate the time that was taken to provide an explanation, but this month we had it was blaring that we had a payment of $400 and some thousand, 480, I think. I don't have the numbers in front of me, for private pay, which was like 460,000 greater than it was the month before. So, and we've talked about the fluctuation with Medicaid and all of that other stuff, but private pay seemed to me that was pretty glaring. And then there was an explanation that it was an accounting, Medicaid approved and Medicaid pending. And I would like a little bit more explanation. I mean, I'm reading that, but I'm still confused by that. So if we could get a little bit more explanation. But you are correct that the finance usually meets after, so we don't get that information in advance. But I do try to look at that and do a compare, and I can't come up with it. The numbers aren't matching, and it's frustrating to me because I can't figure it out.
Okay, this is Rhonda. I wanted to kind of give a kind of a brief explanation as to what happened in the month of February. We constantly are working on our Medicaid, as you probably are very well aware, and we work with the state, trying, when we can get things approved, we have to take it out of a Medicaid pending status and put it in Medicaid. And if we're trying to get liability, which is the money that the resident's family owes us, or the resident owes us, for a particular person, the only way you can get your liability is to take them out of a Medicaid pending status and put them in Medicaid, run your statements, do what you have to do. But there was a problem, and we couldn't figure out what happened in the months of January and February. We had ran some statements for one particular person that's been here for quite a while, and we're trying to get money to come in from the family. We took him out of the Medicaid pending status, put him in Medicaid. The account did not get switched back to Medicaid pending until the next month. So when I called Matrix, which is our computer system, our software provider, I asked him, why this particular system glitch happened? And he explained, if you change it in the month that, like say in January, you change it from Medicaid pending to Medicaid, do what you have to do, run your statements, do your accounts receivable that you have to do, and you switch it back into the Medicaid pending status that same month, you would never see it as a system thing when you're reporting your revenue. But because it didn't get switched back until the following month, it screwed up our AR, to be honest with you. And because that happened, everything's okay now, but it's like the system had to catch up with itself. That's the only explanation I can give you. And believe me, I spoke extensively with Matrix trying to figure this one out. And finally, that's what we attributed it to. And also, there were quite a few people that we got from some really lengthy Medicaid approvals for, which you're going to see in the month of March, a large amount of Medicaid money coming into it. So you talk about fluctuations in your revenue, you're going to see it in March. I'm just going to prepare you. You're going to see an influx of money from Medicaid because they released a lot of funds. So we're moving money around, and that's why the revenue looks weird, because we're having to move it. I hope that explains it. I'm sure it doesn't, but if you work with Medicaid and you work with accounts receivable, it makes a lot of sense to me. The buckets that your money goes into, and it, like I said, it got changed in January and then changed back in February, which skewed your AR.
Go
I
ahead.
hope that helps. I don't know.
That did help. Thank you. And please understand, my questions and my frustration is not directed at anybody personally. And I do appreciate the efforts that you have, the tremendous efforts that you have made to try to keep everything moving in the right direction and trying to reconcile accounts that are obviously challenging because of the lack of timeliness on the part of other people. So I do appreciate that. My frustration is probably that accounting from your area and the accounting that we're getting from the treasurer don't always seem to match, and that's where I am a little frustrated by that, because it doesn't make sense to me. But thank you very much, and appreciate that. And maybe we'll have I could have a conversation with our treasurer and see what we might be able to do. So thank you.
Okay.
So can you clarify then, because if the system messed up and it says, and the note you have in the packet has the person owes over $200,000, and then it messed up and it showed that the treasurer's report had 400,000 or whatever it is because of that kind of thing. Is that really revenue that we had or not really revenue that we had, and that mistake made it look like we had revenue and we didn't really have it, or what?
Yes, exactly what you just said. It's putting money into buckets of, it's money that we're expecting to get at some point in time, but it hasn't actually come. I don't know how, I wish I could bring you all in here and show you what it looks like. And I think you would have a completely different understanding of what we see. What we're doing, we just put money in different statuses based on what they are. And like I said, you know, our bad, we were trying to get statements out to residents' families just so we could get money coming back in, and it does work. But, you know, and talking about even some of the money that came in for the month of February, we did have a little bit of an increase in revenue that month for private pay, just because of how the timing of statements that went out, and money that was coming in for January and February, we were getting paid. So it's just a timing thing. Everything for me is timing. That's why with my Medicare account, if I can get them billed out towards the first of the month, I know my claims are clean. I can tell you that just as sure as I'm sitting here. They're going to sit in Medicare system for 14 days because they have to. That's a payment floor, and then they're going to remit back to me. So if I can get my bills out timely, that money will turn around in the same month, and I'll get paid for whatever month I'm billing for. So it's everything for here. Everything with us is timing. If we can get Medicaid accounts approved, I can get paid. I just got to get them into that approval status with the state. So I just wish you could all sit at my desk and watch what I do, and you go, "Oh, I get it. I get it. It makes sense." But
Okay,
I hope
thank you.
do.
Mr. Gordon.
Thank you, Madam Chairman. I'm just a little bit surprised. No, I'm more than a little bit surprised at reading in the same place where we just were looking about the resident who has an outstanding account in excess of $200,000 that's been waiting on approval from Medicaid for 4 years. How routine is that kind of a waiting period?
That one is a little bit more unusual than most. That resident's account it's been denied, then it's to the point now where the family has an attorney and is trying to get the account approved through Medicaid. So it's been through the normal process, it's been through OIG, and it's been appealed several times. And so right now, the family now has an attorney helping them with their case.
And there was also the sale of a house that had something to do with a lot of this. So.
Okay, thank you. Any other questions for the nursing home? Okay, thank you very much, ladies.
Thank you.
Next up is Michelle Welch and Jason Tabb from Adult and Juvenile Detention.
Good evening.
Present. This is Camille. Since you're both probably not in the same room, Madam Chair, should Ms. Welch go first? Is that okay?
That would be great. Thank you.
Thank you. Go ahead, Ms. Welch.
Anything off my report that anybody has a question about?
Okay, nothing on reports. So
Okay. Any other questions?
I think there's probably questions about what kind of process procedures the jail medical is going through in case of an incarcerated person showing symptoms of COVID, and what what kinds of things are being done and preparing?
Okay. Everybody now has to go through one door. You can't come in any other way. You're screened and you have your temperature taken. Everybody now is wearing masks. The inmates are wearing masks when they come out of their cells. They're locked down now 23 hours just to keep everybody apart. We in medical have decreased the amount of inmates that we see just to limit a lot of transferring through the jail. The nurses are cleaning their stations before they leave after their shift. They're going every shift and spraying down areas with Lysol that you touch, like microwave buttons and things like that. They clean down the exam rooms after each patient leaves. If something, okay, when they first come in, the inmates are screened as well, and they have their temperatures taken. And then if they have any problems at all or a temp, they are given a mask and put in a cell down in booking. If they have no problems, then they're put in N block where they're going to stay until they go to court. And then we get a notification, and then we assess the patient that, well, most of them come in now and say that they have it. I don't know if they think they might get out. That's not going to happen, but they are assessed, and if they're okay, then we go ahead and put them into N block. And then if they go to court and they end up staying, then they're all going to a block where they're kept for 2 weeks. Just we kind of keep an eye on them, take temperatures as we need to. I'm trying to think. If we would happen to have somebody, we haven't so far, that we think might have the virus, then we are going to send them out to the hospital to be checked. But so far, we've not had any problems.
Thank you. So when somebody comes in, is it the booking area that does the testing, or is it your area that does the testing or taking the temperatures and stuff? They're tested when they first come in. They don't even get to us. They don't even get up to our area. They're tested when they first come in. They're screened and they get their temperature taken. And then if they have a problem, then they're put in a booking cell with a mask until we see them. Okay, Member Metzger, did you have a question?
So I'm assuming that when you were talking about people coming in, you're treating or you're evaluating every employee, every correctional officer, every individual who comes in the same way that they're basically doing at the nursing home. Is that kind of what I heard?
Yep, that is actually it. Mm-hmm. And then we've got it to where they're going to, they wear their masks. They were using the N95, but as of today, they're going to just the surgical mask to use. And then they are putting them in a paper bag and sealing it. And then if it's not soiled, and then they use it when they come back on again. But you have to have a mask on before you enter the building.
Member Robustelli, did you have a question?
Yeah, I just want to make sure I heard that correctly. So all of those that are coming in, all of the inmates that are coming in are tested for COVID?
No, they're screened.
Okay.
It's the same screening form that we use. It's, do you have a cough, sore throat, shortness of breath, and a temperature. And then a lot of times they'll say, well, I was just with somebody that said they had it, or maybe I was in Chicago for the weekend. So that's going to be kind of where we're going to go ahead and give them a mask and put them in a holding cell so that they're kept isolated until we can talk to them.
How many have we done any testing on any of those that are housed in the system?
Nope, we've not had to do any testing.
Okay, so we're only testing when symptoms are showing. Is that my understanding?
Correct.
Okay, and how about, now that law enforcement, and I would assume that would include our staff at the jail, they're eligible to get testing because of even if they don't show symptoms, do you know if that's being encouraged in terms of them going out and being tested, just some of them, to get a sense of if it's spreading and there isn't any symptoms among those that are working in the facility?
Well, yes, they are encouraged to go out there
That was me.
and
That
have
was
testing
This
done.
is Camille. I was going to say, I know you can speak to your own employees, and I think Member Robustelli, I think all of the employees who fit the criteria are encouraged, if they have the symptoms or fit the criteria that exist on that given day out at the testing facility. And so I think that is an option for any of.
But I think if I remember correctly, the level 3 now allows public safety officials and healthcare officials without symptoms to be tested. Is that right?
Correct.
So I'm just wondering, now that that's the case, should we be more proactive about sending folks out, especially those that are interacting with vulnerable populations where spread could be much more easily done, and it could have much severe, I asked the same question of the nursing home because I was thinking along the same lines. Should that become part of a standard operating procedure now, just to get a sense of whether or not it's spreading with, and people who are asymptomatic have it? And it's just an open question. I understand there may not be any guidance, but by the time there is, it will be too late. So that's why I'm wondering if they opened it up to that group, there must be a reason for it. It's available and we have the capacity. So should we be thinking about that?
The one problem I could see is if you could test negative and then be exposed a week from now. So I don't know.
So yeah, Ms. Welch is correct. I mean, we have to consider how many tests are available. Certainly at the testing site that we have in our county that's available to regional partners, they have not been using the I think it's 250 a day, correct? But if we do start sending anyone who does not show any symptoms, or who is just concerned, obviously that's their choice, but we don't want to run out of tests. And then I think internally, I would have to, check with any of our policies that we have. We've created some policies just relative to COVID on what that would mean relative to the status of that employee and their ability to be fit for duty if they are waiting for a test. And would that affect any of the flow of our HR? And I'll admit to all who are listening, we have not completely examined any of the implications of whether or not someone who chooses to get the test for COVID-19 when they have no symptoms, even though that is a possibility now, are they then considered fit for duty? And how many days we have to wait for them to get their test is surely a consideration when we're running 24/7 facilities. So it's the dance between really wanting all of the people that live with us and work for us to be safe and find ways to know if they are healthy, if that's the case. But it's also the dance of following the regulatory requirements of the a number of people that we have to have inside of each facility. So it certainly is something that many employers are facing, whether it's a detention facility or any other type of employment. And we're going to look into those issues and try to get them answered.
Thank you. Mr. Gordon?
Thank you, Madam Chairman. I just wanted to be sure I'm understanding something too, that many are screened on the way in without necessarily being undergoing the testing that is available, for example, out at the fairgrounds. Am I creating a distinction where there isn't one, or is that a meaningful distinction that people have their temperatures taken, for example, and if the temperatures are normal, then they proceed in?
Absolutely. Even, well, and Ms. Welch can expound, but even our maintenance staff who come in to fix a leaky shower, et cetera, they're getting screened every time they come in. We've been doing that for weeks, actually. So that's something that you can be assured of that has been occurring. And Ms. Welch, if I'm missing any steps in there, but definitely the distinction is we are not testing anyone at the detention facility or at the nursing home. We're screening people. And so that's a very good distinction.
Right. We even screen our doctor when he comes in, and he's like, okay, I have to do it every jail I go to. So.
And our mail delivery, who does our internal mail, that individual gets screened every time he goes towards into the nursing home entrance or in the detention facility to deliver mail. So it is just our practice. We're quite proud of it. It is something that is very vital to ensuring that anyone with a symptom does not go in that facility.
Thank you. Jason, do you have anything to add about JDC? Or your process any different, or you want to explain your process?
Just 1 second.
We're unmuting Jason. There we go.
Can you hear me now?
Yes.
Okay, we're pretty much mirroring what everyone else is doing, making sure every kid is screened. We've been very fortunate. The kids we do have here have been here for quite some time. We've only had 3 new residents over the past couple of weeks. We are now isolating them, much like the jail, for 14-day period, having medical check-in 2 to 3 times a week with them, just trying to contain them, since we're basically treating anyone and everyone that comes in like they have it. And that's the best practice that we can do at this point, is making sure that we are on guard with everything we're doing and every person that comes in and out of the doors. We've obviously limited all outside access as best we can. I will say thank you to IT. They were able to get us a webcam and computer set up so we can do video conferencing with family members and other personnel. So that's going to be implemented here this week, and very fortunate for that and those capabilities. But we're doing everything we can to, keep everybody safe as we can. We're also, I hate to even say it, we're fortunate that our clients and our staff are out of that major range that people were first targeting as far as the impact range. So, younger staff, younger population. So, and we have very low numbers. We have 6 kids right now.
Thank you. Member Robustelli.
The video access to the webcam and the ability to talk with family, is that free of charge to those that are in, or how does that work?
Yeah, it's actually, I don't know the name of it, but it was a free app. So we're contacting the family. They can download it onto their laptop, computer, or smartphone. So it's a free app on both ends, and it shouldn't cost anybody anything.
Thank you. And as you mentioned, you only have 6 in there right now. And the way the facility is set up, they can be out of their cells and still maintain a good social distance. Is that correct?
Absolutely. Yeah, we're still doing social distancing even in the classroom and in the common areas. The only person right now is the one youth that's new to us. He does have a large area of his own where he can do schoolwork, do any kind of activities, have access to TV. So he's not isolated to a room at this point.
Thank you. Anybody else have any questions for either Shelley or Jason? Member Metzger.
I do for Jason. So school has always been online at the juvenile detention facility?
No, we actually have a teacher from the Regional Office of Education. She's been with us for 7 or 8 years. She does it in-house in our classroom.
And that is currently taking place too?
Yes.
Okay.
She's been instructed to report to work, so we're having school.
Well, good. Okay. The other thing that any releases, there's nothing unique. It's a typical release is a release. There's nothing unique during this time.
As far as why
people being, students being released and, just because somebody, I mean, you haven't had any COVID-19, so you're not, your numbers are low because they're low, right? It's not anything to do with anything you're doing to try to keep people from coming in or screening them out. Is that correct?
Correct. We did not request any counties to remove kids that were on lesser charges. We did have a couple kids that were released on electronic monitoring that may not have been during this time. We are dealing with each new resident on an individual basis and trying to find is this a definite need that this kid needs to be detained right now? Even the police departments, when they call, we had a kid, they called on a warrant. They didn't know what to do because they knew we were trying to keep our population down, but we processed a warrant and brought them in. So there are concerted efforts that people are making, but we're not requesting at this time that they don't detain people.
Okay, my last question has to do with TB testing. January, you had 5, and in February, you had 26.
Yes,
Tell me what happened. Is there something unique?
We did have a large influx of kids at that time, late January, early February. We took a lot of kids that would normally go to Peoria to give Peoria some relief on their population, and they had a low staffing issue. So we had a large number of kids, and I believe those numbers also include the staff members' yearly checkups as well. So that might be the difference in the numbers, is she may have included staff members. I did not verify that with her, but we did have a large number of intakes. I think we had 26 or 28 total kids, and I believe almost all of them were tested.
Okay, thank you. Anybody else have any other questions? Thank you both very much. Moving on, report of the county administrator. You have an item for action. Request approval of an emergency appropriation ordinance amending the McLean County fiscal year 2019 combined annual appropriation for departments under the purview of the Health Committee. Is there a motion? Motion by Martin, second by Robustelli.
Thank you. Thank you, Chairperson. Again, this is similar to what's been going on in many of the committees. We do a lot of cleanup at the end of the year. It is called an emergency appropriation, but there's not necessarily anything emergency about it. It's just an annual task that we do in relation to closing out the general ledger funds. So if you have any questions, either I can work to answer that, or Assistant County Administrator Dreyer is in the room as well. And if there are deeper questions about the finances, perhaps you can answer them.
My question was on the one for the nursing home, where we had all the salaries for part-time, and full-time and seasonal, occasional, and then that was actually spent then on the temporary. I guess, do we have any numbers as to how many FTEs that would have been that we had budgeted versus how many FTEs it actually paid for the temporary?
I do not have any specifics as to how much the line item for the temporary employment equals relative to an FTE right off right here and now. I do not. I'm sorry to say, I don't.
Okay, would we be able to get that for next month so that we can know as to how well we are trying to get off of agency usage versus actual hires? And so that way we can, when we start looking at budget this year, that we can have a better idea as to how that's working.
Yeah, I can definitely do that. And clearly, and I don't think it's obvious, I think, to say that I think the numbers would be a better tell in January and February than they will be in March in hiring. I'm not quite certain that any interview and selection process is going on out at the nursing home at this point relative to COVID, but we will certainly bring that to you next month.
Thank you.
You're welcome.
We have a motion. Any other questions? All in favor? Raise your hand, please. Any opposed? Okay, motion passes. Next week, go ahead, you're still on.
Still on. I have our report of employment activities on page 27. If you have any questions about that, I can certainly answer.
Are there any questions for the county administrator? If none, is there any other business or communication anybody wants to bring up? Okay. We have bills to pay, and I have the memo from the auditor, and that has reviewed all the bills, and they comply with our policies. So Developmental Disabilities Board has a prepaid total of $59,737.04. Motion by Metzger, second by Gordon. All in favor? Got to get used to this part of it. Any opposed? Motion passes. Board of Health has a prepaid total of $127,526.76. Motion by Chung, second by Martin. All in favor? Any opposed? Okay, motion passes. Jail and JDC Medical has a prepaid total of $29,128.03. Motion by Gordon, second by Metzger. All in favor? Okay, that motion passes. And nursing home has a prepaid total of $428,116.01. Motion by Chung, second by Robustelli. All in favor? Any opposed? Okay, motion passes. Please, everyone, stay safe, wash your hands, stay home, cover your coughs, wash your hands, stay home. This meeting is adjourned. Thank you.